I'm Dr. Roberto Victor Ia, and I'll be making some comments on gestational diabetes and related issues. This is a paper from the 1970s indicating how common neonatal hypoglycemia is. In fact, it's probably the most common complication of neonates. Uh, Notice that the authors say the highest incidence of hypoglycemia, 67%, these are blood sugar levels below 30 milligrams percent, occurred in the preterm small for gestational age group. It was 25% in the term small for gestational age infants and 18% in post-term small for gestational age babies. The digital textbook up to date contains the following statement. Transient low blood glucose levels in neonates are common as the source of glucose at delivery changes from a continuous supply from the mother to the intermittent supply from feeds. It is estimated that 10% of normal term newborns cannot maintain a plasma glucose concentration above 30 milligrams percent if their first feeding is delayed for 3 to 6 hours after birth. This is absolutely incorrect. The brain controls blood glucose levels. No human, neonate or adult, should ever fall below 70 milligrams percent. In the previous slide, you will have seen that the statement is made that these neonates are asymptomatic despite very low blood glucose levels. This is a ridiculous assertion. In adults, when the blood glucose drops, if the adult doesn't have signs such as paralysis or tachycardia, they will experience headaches, anxiety, nausea, blurred vision, and a host of other symptoms. But since infants can't speak, they can't tell you how they feel. So it would be preposterous to say that these infants, neonates, are asymptomatic. Normal blood sugar range for everyone is 70 to 140 milligrams percent. These are our children. They have our DNA. There's no reason to believe that their physiology is that of a space alien. So neuroglycopenia, which occurs under 55 milligrams percent, we see this in adults, is very dangerous. So hypoglycemia is never normal in any circumstance. And here is the same fallacy repeated from an online source, Medscape. I quote, neonatal hypoglycemia defined as a plasma glucose level of less than 30 milligrams percent in the first 24 hours of life and less than 45 milligrams percent thereafter is the most common metabolic problem in newborns. Major long-term sequelae include neurologic damage and may impair cardiovascular function. But if you read on, this is seen as acceptable unless the child develops the major signs that are listed below. This is not acceptable. The problem that expectant mothers, therefore, are facing is that virtually all the people taking care of them, whether they be doctors or mid-levels, are operating under the assumption that, first of all blood sugar that's elevated means diabetes, which is wrong, and that hypoglycemia in the neonates is to be expected. The reality is that mothers with nesidioblastosis are undiagnosed and have low blood sugars at birth. All women are treated, if they're considered to be diabetic during pregnancy, with insulin. Insulin administration is very difficult to do, and they're often overtreated. And I've seen women with neurological complications from hypoglycemia. So what is diabetes? This turns out to be a much more complex question than you might imagine. It's not simply a matter of type 1 diabetes and type 2 diabetes. So there are actually 5 or 6 circumstances where the blood sugar can be elevated, only 2 of which are diabetes, type 1 and type 2. The other circumstances are nesidioblastosis, a disorder of the hypothalamus, where it doesn't appropriately track the falling or rising blood sugar, called hypothalamic hypoglycemia. That's my term. Insulinoma, which is a solid tumor. It's not cancer, but produces excessive amounts of insulin on a random basis, like nesidioblastosis, in that it's random release. And then several solid tumors, probably 4 or 5, which produce insulin or insulin-like substances, which can drop the blood sugar for a few seconds, maybe 60 seconds or more, and then this is followed by a Somogy rebound, which gives you the high blood sugar. So what I've determined over the past decade of studying this is that we have the testing capability at this point to sort all these conditions out into their neat categories by doing the following tests I've listed. The C-peptide gives us a rough idea of how much insulin the patient's pancreas is producing. I believe it was introduced in 1988. We need an estimated GFR before we give insulin, because not all insulins are alike. They have different half-lives. We need to do a glucose tolerance test modified to determine insulin and glucagon. You don't need glucola. And you need a continuous glucose monitor to more accurately detect random hypoglycemia. Okay, interpretation. This is the keeper slide. This guides you to the correct diagnosis, no matter who you are. You can't make mistakes if you follow this outline. So I won't comment on this, but you'll see there is a little problem with the solid tumors or insulinoma. You may have to do an MRI of the pancreas to detect the tumor, because the testing characteristics may mimic number 3, nesidioblastosis. Type 1 and type 2 diabetes should sort themselves out quite well, as does the hypothalamic hypoglycemia. I've listed what I call some inconvenient truths about treating what you think is diabetes. Number 1, the Somogy phenomenon is extremely common, and it cycles very quickly. So you may have a low sugar, and then a minute or 2 minutes later, your blood sugar is normal or high, usually high. Number 2, insulin treatment is very hard to do. You have to determine kidney function, you have to select your insulin properly, and you have to follow other things in the patient's life, which may increase or decrease their need for insulin. Number 3, diabetics are very fragile. Stresses, illnesses of various kinds, other medications, especially corticosteroids, which they get as back injections or the dentist may give IV, will elevate blood sugar. Number 4, the hemoglobin A1C test is an index to the average blood sugar over the previous 3 months. It does not detect the main threat, which is hypoglycemia. It is therefore virtually worthless in managing a patient. See the Accord trial, July 2008, New England Journal of Medicine. I believe well over 200 patients died because of the A1C being followed and the patients having recurrent hypoglycemia. When dangerous hypoglycemia is eliminated, the hemoglobin A1C will rise because it's an average. And this will totally mislead the treating clinician. So the patient is getting better and the hemoglobin A1C is getting worse. Not a test to be believed. Yes, diabetics are fragile. Here's a male in his 60s with type 2 diabetes. The peaks, which go from 400 to 600, occur with injection of Decadron at the dental office, treatment with radiation for his cancer, taking Actose from India, which turned out not to be Actose but something else. The factory was shut down by the Indian government, but our patient still got very sick. And inflammation, which occurred a few months after radiation. So virtually anything in the diabetic's life, heart attacks, etc., will cause a change in their need for insulin. So it's not, as your pharmacist might think, unusual to have changes in the amount of insulin prescribed to a patient. This is to be expected. This is a middle-aged male with type 1 diabetes who, in reality, only needs about 12 units of long-acting insulin a day. But because of his prior instructions from his previous doctor, he gives himself additional short-acting insulin when he feels like it. As a consequence, you can see that his blood sugar falls below 50 milligrams % on many, many occasions. He loses consciousness, falls down, breaks bones, and in one incident lost consciousness on the freeway, causing a multi-car pileup with multiple injuries. So the notion that is taught to the public that you can take control of your diabetes and your insulin administration with an insulin pump following a bogus carbohydrate counting techniques and injecting insulin when you think it's appropriate is absolutely wrong and dangerous. And from our estimates, we feel that hypoglycemia is the major cause of auto accidents, and much more so than drunk driving. Remember that all glycemic indices, which are currently promoted by the American Diabetes Association, are absolutely worthless in diagnosing a blood sugar disorder and should not be used in following a patient with a blood sugar disorder, particularly the hemoglobin A1C. So brain cells don't need insulin to transfer glucose across the cell membrane. Brain cells, however, need oxygen and glucose. Otherwise, they die and they leave. If you look at an MRI, you'll notice in patients who have had very low oxygen, like drowning patients, or very low glucose, there are white matter lesions. Just to remind you that our blood sugar oscillates very rapidly, probably every 60 seconds, between the normal ranges of 70 and 140 milligrams %. Most times hypoglycemia can be detected with a continuous glucose monitor. I would say about 80% of the time, but sometimes they will be missed. The importance of the Somogyi phenomenon cannot be overestimated. First described in 1938 by Michael Somogyi, PhD. He was a chemical engineer. Dr. Somogyi was the first person to purify insulin in 1922 for Eli Lilly Company, and was present at the first human administration. There is no dawn phenomenon. This was a theory created after Somogyi described the rebound that he described. The dawn phenomenon is merely nocturnal hypoglycemia followed by a Somogyi rebound to an elevated blood sugar. If you do not appreciate how common the Somogyi rebound phenomenon is, you should not be treating blood sugar disorders. What Dr. Somogyi observed was that increasing insulin dose was commonly followed by an increase in blood glucose levels, and lowering insulin dose might be followed by lower blood glucose levels. At first, this seems counterintuitive, until you understand that the brain, specifically the hypothalamus, controls blood glucose levels. The central nervous system detects levels of glucose every few seconds and controls the release of insulin and glucagon from the pancreatic beta and alpha cells respectively through the autonomic nervous system. So the central nervous system is programmed to counter falls in glucose by stimulating the release of glucagon. Glucagon causes a rapid conversion of glycogen in the liver to glucose. This torrential glucose entry into the bloodstream far outlasts the period of hypoglycemia which provoked it. Patients can rebound from low blood sugars, very low blood sugars, and rebound up to hyperglycemic levels of 500 or 600 milligrams percent. We have seen this several times in our office. This is the line graph report from a patient I treated about 10 years ago. Notice that early in the recording, her blood sugar has been normalized, and then because she failed to lower her insulin dose, she begins a series of Somogy rebounds to 500 milligrams percent. When she comes back to the office, I persuade her to drop her insulin dose. And with the lower insulin dose, notice that her blood sugar falls. So this is the American Diabetes Association paradigm, which has caused untold suffering and death throughout the world. And this is quoted from their Diabetes Care article, January 2012. Hyperglycemia defines diabetes, and glycemic control is fundamental to the management of diabetes. In reality, hyperglycemia can be the result of a rebound from hypoglycemia. So this is very misleading and very damaging. I just want to touch on a few myths about blood sugar that are quite common. Number one, that type 2 diabetes is a result of insulin resistance. That's absolutely nonsense. You never become resistant to your own insulin. You don't go to sleep at night in your 20s or 30s and wake up with all your cells resistant to your insulin. There are abnormal forms of insulin, which were largely documented in the Japanese literature, where the insulin molecule is malformed at birth and cannot facilitate the transfer of glucose into the cell. These babies die in infancy. Number two, obesity causes diabetes. Most of my diabetic patients are not obese. And in countries where there is famine, such as Somalia and Ethiopia, starving diabetics experience a rise in blood sugar. Number three, you can reverse hypoglycemia with sugar pills or food. Don't depend on it. Not true. If you have severe hypoglycemia, you'll need a glucagon emergency kit. Number four, antibodies to the pancreas are the cause of type 1 diabetes. Not true. No long-term studies have been done. The antibodies change over time. So this is absolutely not a useful piece of information. Better to measure a C-peptide, which actually, if it's very low, tells you that the patient is prone to diabetic ketoacidosis. So that's a practical piece of information. Number five, lifestyle changes bring on, prevent, or can cure diabetes. Absolutely not true. Number six, certain racial groups are more prone to diabetes. Again, not true. What we see is a correspondence to poverty. So these racial groups, such as American Indians or poor blacks, generally are more prone to diabetes, I think, because diabetes is likely a virus, and that's judging from reading dozens of papers on the subject from China and from Britain. So it's probably a viral etiology and has nothing to do with genetics. Beware of false knowledge. It is more dangerous than ignorance. So in summary, despite our modern technology, you cannot depend on your obstetrician gynecologist or mid-level practitioner to make the right decision regarding your life or the life of your unborn child. This is true whether you are being cared for at a university center or in a rural community. These people have a very poor knowledge of blood sugar disorders. You will receive the same relatively poor care if you have a blood sugar problem. This is not because your practitioner does not want to do the best for you and your child. It is because your practitioner has been systematically misinformed during their training period and continued to be misinformed because of political and financial interests that are beyond their control. Thank you for your attention.